Well, bladder cancer is quite a wide spectrum of disease, from quite low-grade non-aggressive disease to higher grade, more aggressive cancer that can invade into the bladder wall, and if left it will spread somewhere else. So essentially you want to consider surgery if you've got a form of aggressive cancer that's still confined to the bladder, that's got potential for spreading further. It's a treatment to try and eradicate dangerous disease. Usually transitional cell cancer, which is the main cancer of the bladder. There are some rarer ones, squamous cell, small cell cancers, adenocarcinoma, that probably surgery is the only option for, but in general terms, the commonest one is for the aggressive cancer that's still confined to the bladder to try and stop it spreading. Well, radicals often use the term for cancer surgery to mean you're not just taking the organ out, but the surrounding tissues, the fat, maybe the lymph glands that drain that organ to try and remove the potential for the cancer. So in a man, radical cystectomy would mean taking out the bladder, the prostate, and the local fat and lymph glands. In a woman, usually would remove the bladder, the uterus, the ovaries, and the local lymph glands. Well, cystectomy, radical cystectomy, is quite a major operation. It involves taking the bladder, prostate, uterus out, but also then doing some form of operation on the bowel to make a urinary diversion or reconstruction. So first of all, you've got to make sure the patient's fit for it. As the classical patient with bladder cancer is actually an older man who's probably been a smoker or an industrial worker. Those are the patients with the same risk factors there are for heart disease, for example, and lung disease. So you know, sometimes dealing with quite a sick population anyway, so optimising their fitness. You've got to make them aware of what the operation entails. It's a major procedure, and if they're going to have a urinary diversion, get them in touch with a stoma or specialist nurse to discuss the implications of having to deal with a bag for the rest of their lives afterwards. So I guess making sure you've got somebody who's in optimal physical condition, considering you're often dealing with a less fit population, and making sure they're aware of the consequences and the long-term need for dealing with, for example, a stoma. Well, I think classically the operation is performed through an incision, through an open operation, for at least from your belly button down to your lower part of your abdomen, sometimes a bigger cut than that. That's the standard operation, has been for 50 years or more. It's a fairly traumatic procedure, so over the last few years what many centres have been doing is trying to reduce the trauma by using minimally invasive approaches. Some have done it laparoscopically. It's quite difficult. It's debatable whether it's any better than open. Robotics, a form of laparoscopic surgery, it's more precise, it's less invasive than open surgery, so many centres are now trying to do the operation robotically, or either in the whole operation or at least large parts of it. It can be difficult to prove that there's advantages in terms of long-term outcomes from one over the other, but personally, you know, the operation that involves the least trauma is the one that I think allows people to recover more quickly. Therefore, you know, robotic surgery is a good option for many people, not for everybody. They're both designed to cure the cancer, so first of all, however you do it, you've got to be sure that that's being achieved. After that, the advantages of a less invasive approach are less trauma to the individual. Therefore, if you've got smaller wounds, smaller cuts, puncture wounds, pain relief is easier. You need less opioids, for example, or sometimes none. General physical recovery is quicker. Mobilisation, reducing the risk of chest complications, DVTs, pulmonary emboli. Those things are associated with long operation and lying around in bed while recovering. So in terms of recovery and safer recovery, a less invasive approach should actually give you advantages. A radical cystectomy, how you do it, partly depends on the approach you're going to take. Obviously an open operation, both forms need a full anaesthetic. An open operation would involve an incision in the abdomen. A robotic operation involves putting a series of telescopes around the abdomen through puncture wounds. There is an in-between phase where you can do a lot of the operation telescopically with a robot, and some of it you may finish off through a smaller incision. Essentially what you do inside is the same however you get to it, and that first of all is to remove the lymph glands from around the bladder, and then remove the bladder in a woman usually with a uterus and a man with a prostate, dissect it free, bladder does have a number of large blood vessels attached to it, so making sure they're all controlled, there's no bleeding, and essentially freeing the whole thing up and getting rid of the offending organ. The next stage is to do a second operation, which involves either, all will involve getting some piece of intestine to either produce what's called a conduit, which is a small piece of bowel that you take out of the normal circulation. You attach the kidneys to one end and bring out the other end as a stoma or spout to the skin. Or you can take a slightly larger piece of bowel and try some form of reconstruction or slightly more complicated pouch, so you're not leaking urine all the time. You've got to have some control over the urine output. Afterwards, after you perform the operation, however you do the diversion or the reconstruction, you will need some form of drainage for a period of probably a minimum of 8 to 10 days, sometimes longer. At least one catheter, and maybe 1 or 2 other drainage tubes, just to let all the bits you've joined together inside heal up. So there will be a number of tubes sticking out the abdomen, probably for a minimum of 7 to 8 days, and possibly longer than that. Well, a male cystectomy, almost always, and it's not in every case, you take the prostate out, so you take the bladder and the prostate as well. The inside of the prostate, although the prostate is a different organ, it's a sexual organ, but the lining that you pee through has got the same lining as the bladder, so if you leave it behind, there's a risk of cancers recurring in the prostate. You can, in very specific cases, maybe younger men who've got cancers well away from the prostate, who maybe still want to be reproductive, leave the prostate behind and keep a very close eye on it afterwards. That's a very small group of very specific cancers in specific groups of men. So in a man, the normal operation is remove the bladder and the prostate. In a woman, you would normally take the uterus and a small sliver of the front of the vagina away. Again, there can be very specific circumstances in a young woman. I've had a couple in their 20s with quite nasty bladder cancers. You can leave the uterus behind if the cancer's away from the uterus side of the bladder. Most cancers obviously tend to occur in women who are past the menopause, so it becomes a bit less relevant as to whether the uterus is there or not. Once you remove the bladder, the options for dealing with the urine, well, there are several. The most commonly used one is what's called an ileal conduit. An ileal conduit is taking a small piece of small intestine out of circulation, joining the bowel back together again, and then you take this isolated piece of bowel and you join the ureters, the tubes from the kidney, to the lower end of it, and you bring the other end out through the skin to the side of the abdomen and form a stoma. So essentially the urine just leaks out all the time and you have to wear a bag over it. And that's, in most countries, by far the commonest form of diversion. There are other forms of diversion, because that's incontinent. You can form continent diversions, which are more complicated. Something like a Mitrofanov, for example, where you use a larger pouch of bowel. You isolate and, for example, use the appendix to join the skin to the pouch. Because it's at a low pressure, you can then, it shouldn't leak then, but you need to drain it with the catheter, either through the skin or through the belly button every 3-4 hours or so. So it's a bit more time consuming, but it needs a bit more individual interaction to make it work in the long term. So that's probably used relatively uncommonly. The other option, if possible, is to try and make a new bladder if you've taken the bladder out, and if it's safe to do so in terms of cancer treatment. In both a man and a woman, if you leave their urethra and the valves, the sphincter behind, you can take a larger section of about 55 centimetres of small bowel, isolate it, open it up and make it into a pouch and sew it back down onto the urethra. And that is quite effective in men, and in my view is actually more effective in women. If you've got to be able to leave the urethra behind though, and the valve mechanisms, otherwise it will be leaking all the time. So it isn't applicable to everybody. I guess you should say that the patient often selects, first of all, the default position is an ileal conduit. Most people will be offered that first. You can talk about the alternatives. If the urethra is intact and the urethral sphincter is intact, and it's safe to do so because of clearance of the cancer, you can talk about a bladder reconstruction. The other options, such as Mitrofanov or even occasionally diversion into the rectum, are for people who really aren't suitable for reconstruction but don't really want in any circumstances to have a stoma and wear a bag all the time. So that's quite a small minority of people. So you really should go through his options with the individual. There are some people obviously who are not suitable for some forms of it, but you can give them the options. And we have specialist nurses and stoma nurses who can go through the pros and cons of all the different forms. Ileal conduit, you wear a bag all the time. Occasionally you get skin problems around it. Bladder reconstruction, however good you are at doing it, even in the best specialist centres, a small percentage of people never quite get their full control back. In men and women, probably 10% at least have some long-term leakage problems. In some series, as many as a third. So there's pros and cons with each. I guess the idea really is to go through those pros and cons with the individuals and let them choose what's best for their lifestyle.